the panel up here that we're going to do a couple cases, hopefully. So if the panel can come up, that would be great. And if we could pull up my first case. So this is just a very typical case, very high-end athlete. She was a triathlete and a attorney. This was way back in 2001, so this is very early in my career doing MIS T-lifts. But you can see that this is a kind of a classic, highly dynamically unstable spondy at 5'1". You can see in flexion she moves almost a full centimeter, and she almost reduces completely in extension. And then you can see the classic on the left-hand side, isthmic spondy, pars defect with foraminal stenosis, and then on the MRI you can see similar with degeneration of that disc as well. So really the surgical plan is one of the three, right? We didn't, at least in 2001, we pretty much only had anterior and posterior procedures, but what would we, someone that's been in practice, who's been in practice the longest here? Justin. So what would you do differently in this patient from your first year in practice till today?
Wow, that's a good question and a tough question, because on your first slide, I would have put a standard ALIF on that list of potential options. And especially for the young patient, if it's a compliant young patient, I still think a ALIF, standalone ALIF without any posterior support is a very reasonable alternative in someone who's that flexible.
Even with that much dynamic instability, you're still comfortable not backing that up posteriorly?
Yeah, in fact, because of that much dynamic instability. If they are rigid and forward, they are grade 2 or grade 3, I'm never going to do that as a standalone. But they basically reduce almost back to neutral on their extension. And that's why I say a compliant patient, because they need to be just pretty chill for 3 months to allow their fusion to take. If they're going to not be compliant, then you have to back them up.
I think there's very...
What's that?
So I would always back this patient up, and I would also say probably, and certainly there's some groupthink and some inbred training at NYU, but I don't think any of us would do a standalone ALIF here. And my feeling is that doing an ALIF, which would be my choice for this patient, and then backing it up with MIS perc screws, just there's a very low downside for the patient to have those 2 1-inch incisions and another hour of actual OR time. And then you have about the strongest construct you can have versus something that's fairly tenuous and where you're relying on potentially a post-op orthosis and patient compliance and maybe a real failure, because that standalone ALIF that fails in this sort of circumstance then becomes a very challenging revision scenario.
And are you putting bone graft posteriorly or just locking down with screws?
So in my MIS TLIF, I drop a tube and do a formal posterolateral fusion. In an ALIF like this with infuse, which is what I would generally use, I generally just put screws.
Charlotte, let's just say now he's a 30-year-old male, and you had mentioned retrograde ejaculation. Would you still do the same procedure if he was a male?
It depends on if he's done, if he's having children or if he's still in sort of the reproductive years. So I would have a conversation with him about it. The small risk, but if he still wants to try and have more kids or any kids, I think it's very reasonable to not go anterior as long as he understands, the risks and benefits. I think now that we have some really good expandable cages, and you can see he reduces really well, or if it's a guy, he reduces really well on extension films. The reason to do an ALIF is because that disc was so big on the x-ray, but being able to get in that disc space is not going to be super challenging. You could distract on the screws because in a young, healthy patient, you're not going to be so worried about screw loosening with distraction. So those are some things that some techniques that you could employ to really get into that disc space. And I think that in a young, healthy patient, doing an MIS TLIF could be a reasonable option if you don't want to go anteriorly.
I think in this patient, you'd get better correction of lordosis with an ALIF. And, I think that would set the 4-5 up disc in a little bit of a better way. I mean, I think this is a patient where I'd put at least a 12 degree, if not a higher lordotic implant in. And I still think an ALIF is probably the best operation for this. And then, you're never going to worry about a pseudoarthrosis. And I would put screws in something that dynamic just because, I've seen sacral fractures and, fusing someone to the pelvis is really not a fun operation to do, to have to fix that in a fairly young, healthy person.
Coy, anything to add?
Not really. In young people in general, or maybe in general, I'm just avoiding kind of multi-approach surgeries, except for very, very big deformities where I want that better support more inferiorly. I would MIS TLIF this. I think, again, it's a single approach. It's 2 small incisions. You're able to, I think the bigger disc space actually helps facilitate, the inner body placement. Charlotte mentioned the availability of expandable cages now that that can quite easily fill that disc space and provide the support. Easily reduce the spondy just with the placement of your screw heads and the reduction of the screw heads to the rod.
And Justin, not to belabor the retrograde ejaculation point, but if it was a male and he wanted children still, would that change your plan?
It's a harder decision at the age of 30, and I do talk to some of the patients about that, all the males, and I let them decide. I tell them it's a 10% risk.
Which is probably higher than it is, but
I tell them, yeah, it's a 1 in a 10. I've never had a patient say, look, I'm just going to bank some sperm. It seems like too much of a headache, so they'll just choose to go posteriorly if they're worried.
So what I actually did is an MIS TLIF, and I don't know why these are in here, but if I was debating you, Justin, this is why I would say open TLIFs are horrible, because look at that erector spinae musculature. It's just wrecked. So the multifidus is wrecked. But what we did in this case is an MIS TLIF, and that's what MIS TLIF look like on axial MRIs post-surgically. So very less tissue trauma, less marbling of the erector spinae musculature. And so this is what she looked like. And again, I can critique myself for a couple reasons. Number one, but remember, this was 2001. So if I did it today, I would have definitely sought more lordosis of that segment. But you can see this is the old variety Sexton screws, so I did them percutaneously. And all we had back then was structural allograft, so that's what we did. And she went on to heal quite well, and she's done well for 20 years. So that was an early MIS TLIF that we did. So.
Did you let her go back to triathlons?
She let herself go back.
Right.
And and the other thing I found early in my career with these kind of more prominent implants, the pedicle screw heads were much larger than the new ones, was a lot of patients had postoperative muscle pain, persistent postoperative muscle pain. So I used to take out a lot of these screws. I take out very few now, and I think it has to do with technique and downsizing of the implants.
Question. So patients who have isthmic spondylolisthesis certainly have a very different set of pathology than patients who have degenerative disc disease and disc herniations. That those patients often have multiple levels that are problematic. Obviously, their college and makeup may predispose that kind of degeneration. However, the isthmic spondy is a little bit different. There's so many people walking around who were born with sacralized L5 segments. My gestalt in general is that a patient who has isthmic spondy at 5'1" and a good-looking spine above who goes on to solid fusion, that that patient probably has a better prognosis for return to full activity, high-level, challenging activity than a patient with a different underlying pathology. I'm curious if you'd share that thought process.
Yeah, absolutely.
Can you go back to the pre-op X-ray?
Sure.
Or the pre-op CT scan? So this was the situation I had with my own daughter, only she was slipped quite a lot further than that. She was almost a grade 3. When she was 19, she was singing in choir, and I knew she had a meniscus spondyle from gymnastics when she was little. And when she was, and I kind of just said she could live with it. When she was 19, she said she was singing in choir. She couldn't stand long enough to perform. So, and she's a little chunky. So, I went anteriorly, and her.
So you did her surgery?
With my partner. And her sacrum was much more horizontal. So the secret to that is you almost can't see the interspace when the sacrum is very horizontal. So what I did was osteotomize the anterior edge of L5 so I could see the interspace. And then put in a large cage. And when you do that, a lot of the ALIF plates, and she's 29, so this is 10 or 11 years ago, a lot of the ALIF plates won't fit. So I actually took a plate bender and reversed the curvature of the plate so that the L5 screws are angled up into the body and the S1 screws are angled down. And she didn't have leg pain. And she's gone on to get a master's degree in music, and now she's in nursing school and does everything she wants. I was really torn about whether to do put the screws on her, but I also knew that in the future, if she did break down at L4-5, I would be glad that I had to put screws in at 5, so that remained a viable option without having to take out previous hardware down the line. So my rationale was exactly like Dr. Tortolani's, and actually it turned out to be excellent and it worked. But that trick of knocking off and osteotomizing the anterior aspect of L5 will allow you to see the interspace a lot more clearly in a patient who has a very horizontal sacrum.
That's great. Yeah, thanks for that comment. And Jim, I want to go back to one of the points you raised earlier about the posterior musculature. So, that's something that we see a lot on MRI scans postoperatively, especially with the traditional, pedicle screw technique where you're exposing out wide to get your convergence angle. But in elite level athletes, and I've done several of these now at 5'1" with a grade 2 spondy, they get back to play at a high level. And so I have a hard time reconciling what you see on the MRI scan, which can look sort of scarred in or fatty infiltration, but then they're functioning really well. Have you ever seen any correlation with the MRI and function?
They've done some functional studies a long time ago, and there was some diminished strength of the erector spinae in comparison, but not really good studies in my experience that I know of in the literature. Any from the panel that we know of? And I think 5'1" might be a different
little bit different
situation,
beast, yeah.
because oftentimes if you look at people preoperatively at 5'1",
Yeah, they're
they have
kind of
a
wasted.
lot of fatty
Yeah.
infiltration there, versus if you go higher in the lumbar spine, it typically looks much more robust, much less marbled.
That's
So
a good
maybe
point.
it's a L5S1 versus a
Yeah.
higher lumbar segment.
Some people in deformity are starting to look at this, the amount of like the fat percentage in the paraspinal musculature, and it can affect gait. Functional outcomes other than a little bit of walking disturbance. That's about it.
Any other questions from the audience?
Just a comment. I think for your general community spine surgeon, to do an MIST lift well, really what, if you do an MIST lift well, the outcomes are going to be better, but it's hard to get there. The learning curve is not easy. And I think, I see a cages are way posterior, they're kyphotic, breaking down the next level. So, I think it's important for there to be good education on learning the MIS TLIF technique, which I'm happy to see is getting better. But I honestly think that for most of us, we've all learned over the technique. Our training is intuitive, it's what we do. And I think the outcomes at the end of the day, if you do that well, patients are going to do reasonably well. It's nice, and I think would be good in the future if all of us do become fast on MIS.
That's an awesome point. MIS is a great surgery for a good surgeon. It's a disaster for a shitty surgeon. It is. Anybody can do an orthopedic. But an MIS, if you're not a good surgeon, it's a disaster.
So to speak on that, I'm at a fellowship program. So we train somewhere between 3 and 5 fellows a year, and I've been doing that for 20 years. I can tell you I am a much better educator of this technique now than I used to be. And it has a lot to do with so many different factors. But I can tell you, out of those, let's say 4 fellows a year, 2 at the end of their fellowship are good at doing the procedure. 1 probably over time will get there, and 1 will never get there. So the problem is if you go into practice and you're that one person that is not capable of doing an MIS procedure, and now all of a sudden you feel this need to do it, then you're going to have a lot of difficulty and you're going to get a lot of bad outcomes. But there's absolutely those surgeons that you just know right away, training them as a fellow, that they have the ability, and those that don't. The problem is telling those that don't that they don't. That is a big, big deal. I do tell them, and maybe that's why none of my fellows are here. But no, I tell them, listen, you're a good surgeon, just do it open. Please, when you go into practice, don't think now you're going to learn how to do MIS procedures. You just know those patients or
That's a
surgeons.
great point. And that's also coming from a fellowship that attracts the very cream of the crop. So
I think the biggest problem I
Back to
see
that,
with this is the lack of the amount of disc that the people take out when the operation fails. They think that they can put in an like cage and they don't take out anywhere near enough disc. And I'm not in a training program now teaching, but I was for quite a while. And I think the thing that has to be emphasized to the fellows is the meticulous removal of the end plate and putting the cage as far anterior as possible.
And we've done some studies looking at that, and experienced MIS surgeons can get as much disc out via a unilateral approach as doing it open. So
It takes time.
it takes a lot of time.
And don't forget, it takes 10,000 hours of practice to get good at this stuff. That's years.
Yeah.
So when you're coming out of fellowship, most of these guys are excited and happy and think that they know a lot. They unfortunately don't even know what they don't know. And they probably rush through the operation, not taking enough time to do the meticulous discectomy.
Well, I would argue that's the case for any person coming out of fellowship. You think you can do everything, but I think that there's an opportunity for when you come out of fellowship to recognize your limitations if you have a fellowship director who's identified that, and spend some time going to different institutions and learning from other people. I think that your training doesn't have to end at the end of your fellowship, and if you just take some time to go around and continue to learn. Sometimes the spine fellowship being a year, sometimes we feel like maybe it should be 2 years, So I think, yes, 10,000 hours for anything we do in surgery, and it's upon us at teaching institutions to recommend to people another fellowship or take some time and go visit places and learn how people do things.
I would also just add that, listening to Justin talk, I used to be very stressed out coming in to do an MIS TLIF. It is a technically demanding procedure. There is a learning curve. I did 0 of them in fellowship. But now my sunny day is coming in to do an MIS TLIF because I don't have to do this big bloody exposure. I don't have to watch the patient ooze. I don't have to do this big closure and look at this 6-inch incision, and then my patient goes home quickly and they do well. So it's hard to reconcile something that is perhaps a more technically demanding, more challenging procedure that does take a learning curve, but once that learning curve has been surpassed, really does have measurable benefits.
How can you make open surgery sound archaic? I would tell you that to me, minimally invasive is about efficiency. So, to me, on that case, I could do an A-lift about 30 minutes, flip the patient over, do an open screw placement in about 30 minutes to get that patient off the table. And the muscle retraction time, I think, is the key when it comes to open surgery. So, if you looked at the NYU study there, the average open and closed surgeries were 4 hours. For 1-2 level fusion, it never takes me 4 hours. If I'm doing an anterior antibody fusion, I don't go out to the transverse processes. I'm putting DMT in the front. I go out, I carefully peel those muscles off. It's bloodless, basically. You go to the facet joints. You don't even have to pop off the lamina in an isthmus spondy, but I do. And I put the screws in about 30 minutes, close the fascia tight. So to me, I think, there's no doubt a skilled surgeon that can do MIS I think it's an art and it's great. But I think, when you belittle open surgery, if it's done well and efficiently, I know you're not belittling, I'm just joking about that, but if it's done well and efficiently, I think it's about handling soft tissues, about doing things efficiently. So the learning curve, for me, I thought I could do an open surgery well 20 years ago. Now I can do it even faster and more efficient 20 years later. So it's getting less and less invasive as I go on. So I think it's about handling soft tissues, about perspective of moving the retractors and so forth. I think you can get away with longer retraction time with minimally invasive because you're in a tube that's not putting a lot of retraction on the muscle versus the big Gelpies and so forth. But I think you can do open surgery in a more minimally invasive way and get very similar results.
You must have nice skinny patients in Orange County.
For the interest of time, it's a couple minutes after 10. Thank you, everyone, for this morning.
And just this afternoon,